Welcome back to the Ninja Nerd Podcast. Today we're talking about hypercoagulable states. I don't know what that means.
You be clotting, bro. You be clotting.
I got a lot to learn in this episode.
Yeah, we got a lot to learn. Yeah, we'll do it together.
All right, sounds good. So we have two cases, and then we're going to end the podcast episode then with a general discussion at the end. Case 1, we have a 32-year-old female presenting with pain and swelling in her left leg after a long flight. The patient reports that she developed left calf swelling and tenderness 2 days after returning from a 10-hour flight. This is her third episode of a DVT, with prior events occurring at ages 25 and 28. Both previous events were unprovoked and required anticoagulation for 6 months each. She has not had significant bleeding and complications with prior anticoagulation. The patient also mentions that her father was diagnosed with a blood clot in his 40s and that her paternal aunt had a pulmonary embolism after childbirth. She denies smoking, oral contraceptive use, or recent surgery. For our exam, her vitals: BP 120 over 80, heart rate is 88, her temp is 98.6 Fahrenheit, and her O2 sat is 97% on room air. Her left leg is swollen, it's tender, and she does have a positive Homan sign on that left leg. For her cardiovascular, there are no murmurs or jugular venous distension, and her skin, no petechiae or purpura present. We do some lab work, we get back the following. D-dimer is elevated, Doppler ultrasound is positive for left leg DVT, and her PT-INR and PTT is normal. When would you screen for inherited thrombophilia, and what clues are present in this patient?
Yeah, so thrombophilia is another word for hypercoagulable state. It just kind of means you're more prone to clotting. And so thrombophilia can be inherited, and it usually is in a patient who there's a couple different things that you want to think about. So here's the thing. When a patient develops a blood clot, DVT, PE, those are the big ones. There's some other ones too. You want to definitely think about the most common reasons. So you got to go back to kind of Virchow's triad. You remember that? Like stasis of blood flow.
Yep.
So if you're immobilized for a long period of time, whether it's due to your post-operative kind of a healing, you're paralyzed on a particular side of the body, you're on a long flight, which this person was, and then there was endothelial injury, so surgery, smoking was big factors there. And then there was one more thing for Virchow's triad. It was the hypercoagulable state. And so the acquired things are going to be a little bit more common. And so those are when you think about things like, pregnancy, oral contraceptives, malignancy, antiphospholipid syndrome. But often when we think about these things, we kind of miss the inherited factors, or we overthink about them. We think they're very common. They're not very common. They account for a very small percentage. So for most of the times when people develop DVTs, it's usually due to surgery, especially orthopedic surgeries, lots of immobilization, malignancy is the big one as well, and smoking, things like that. It's not as common to see a hypercoagulable state. And so it's especially inherited.
I was going to say, so in this patient, we really have to look at her history.
Yeah, and so what really makes me think, okay, this is probably not as much of the stasis factors. It's probably not as much of the endothelial injury types of factors. It's probably not as much of the acquired hypercoagulable state. This could be inherited. And there's a couple different reasons why. One is a very strong family history. So when I have a first degree relative, in this case, it was her father, and then on top of that, the aunt, that tells me that there's a very strong family history of DVTs and subsequent PEs. And so that's definitely concerning. The second thing is recurrent VTEs, and VTEs is just venous thromboembolisms. So this is the patient's third episode of a DVT. So if I see one or more recurrent DVTs without any other true risk factors that suggest the Virchow's triad, that's another big one. So recurrent DVT or PE, strong family history, first degree relative, and usually I like them to be less than 45 or 50 years of age. This father was 40, all right? The other thing that's really important is clots in unusual locations. And so most of the time it's DVT or it's PE. But if you ever see a Budd-Chiari syndrome, which is a clot in the hepatic vein, a portal vein thrombus, or mesenteric vein thrombus, or cerebral venous sinus thrombosis, then I would definitely consider working the patient up for some type of inherited thrombophilia. I would say those are the biggest reasons for me is a strong family history, recurrent VTEs, and then clots in unusual locations. The only other reason I would think, but it's not so much the inherited, it's more the acquired, especially antiphospholipid syndrome, is recurrent miscarriages or like greater than or equal to 3 abortions spontaneously, usually at less than 10 weeks gestation. So that's another reason to work up a patient for thrombophilia, but more the antiphospholipid syndrome.
How about testing? Is there anything more, like what other tests would you do than what we had initially ordered?
Yeah, so you kind of got started in the sense that this is definitely a DVT. Whenever you get ready to order things for thrombophilia. So for this patient, I don't see a lot of other risk factors except the 10-hour flight. So there was the, immobilization, but to have that and then have multiple episodes of a DVT, and then on top of that have a family history. And I'm like, I gotta work this patient up for an inherited thrombophilia. So what I would do is I would send off a couple of them. Factor V Leiden is by far going to be the most common inherited thrombophilia. The next one would be prothrombin gene mutation. The next one would be protein C and S deficiency. And then antithrombin 3 deficiency would also be another one. And so what I would do is I would send off what's called a factor V, like it's an activated protein C resistance assay or screen, and that's the first thing I would do. The second thing I would do is I would send off a prothrombin, like a PCR, to see if there was a mutation there, and then I would check the levels and activity of protein C, S, and antithrombin 3. So if factor V, if it's a mutation there, what happens is factor V is supposed to, it basically helps in activating the formation of thrombin. So 10 and factor V combined activate thrombin. So in factor V Leiden, that factor V is supposed to be degraded by protein C. But you have a mutation in these patients where it doesn't get degraded or broken down by protein C. And so it stays active and it keeps activating factor 10 and activating thrombin. So you keep clotting. And so if I checked the assay and there was a high amount of activity of the resistance against protein C, that would tell me that this is a factor V Leiden mutation. You can also check there's a specific mutation. It's the R506Q mutation. That's for your USMLE step 1, not for the step 2 or for your clinicals. The next one is I would check the prothrombin. And G mutation, I'd look for the G20210A mutation. That one you actually do have to know. Okay. It's very annoying. Look for that type of mutation. You'll do like a PCR test, and you'll look for, again, the G20210A mutation. The next thing is I would check the protein C levels, and if that's decreased, it could be protein C deficiency. Protein S, if those levels are low, it could be protein S deficiency. And if antithrombin 3 levels are low, it could be antithrombin 3 deficiency. But you should work the patient up for nephrotic syndrome as well, because nephrotic syndrome can cause a acquired type of antithrombin 3 deficiency.
How does timing play a role? Does it matter at all when you're testing these?
Yeah, you got to be careful, and the reason why is I think really only factor V Leiden and prothrombin gene mutations you can test for when a patient has an active thrombus or they're on anticoagulation. Those are the only two. They're not really as much affected by anticoagulation or as much affected by an acute thrombus. Generally, we like to try to defer testing for these once the thrombus has dissipated and they're off anticoagulation for all of them, ideally. But generally, I would say that, a lot of the times in the hospital, they'll check all of these things anyway. It's not going to be accurate, especially protein C, protein S deficiency, antithrombin 3. Antithrombin 3 can be affected by heparin, protein C and S can be affected by warfarin. So it's really important that if a patient has an active clot or they have any kind of anticoagulation, to avoid testing for those. You could, again, consider testing for factor V or prothrombin gene, but otherwise I would just wait until the clot is dissolved and then, again, treat them, get them off the anticoagulants if possible, and then test them.
Walk us through the acute and more of the long-term treatment for this patient.
So acutely, for this patient who has another DVT, I would start them on heparin, low molecular weight heparin, or you could do, depending upon which one your choice is, unfractionated. Low molecular weight heparin is a little bit more ease of use. So it's an injection. You don't have to keep getting monitoring. Yeah. You can check their anti-XA level, but you don't have to. So that's my preferred one, is low molecular weight heparin. But if you want a closer titration and you want to be very, very careful and you want to monitor their PTT or their anti-XA level, you could do unfractionated heparin. So I would start one of those two, and then try to get them therapeutic. The determination to say how long do they stay on anticoagulation, is it indefinite or not? That kind of depends. So I would say if a patient has recurrent clots like this patient does, they're going to be on anticoagulation for the rest of their life.
I would hope so. I mean, you can't keep risking that.
Yeah, and so that's the big thing is recurrent VTEs, a strong family history, unusual clots in different locations. If they kind of fit that bill, I'm probably just going to go ahead and anticoagulate them for forever. Weigh out the risks and benefits. Obviously, with putting patient on an anticoagulant for a lifelong term, you risk bleeding. So you have to have the discussion with the patient. But I would say for pretty much all of my high risk ones, which I would say the only one that's not really super high risk is factor V.
Okay.
That one, unless it's like really bad, unless you have like homozygous factor V Leiden mutation, so meaning both of the chromosomes, those alleles are knocked out, then I would say that's a risk. Protein C and S deficiency, antithrombin 3 deficiency, all of those, I would definitely be putting these patients on lifelong anticoagulation. They're pretty high risk. Prothrombin G mutation's a little bit lower risk. You could maybe get away with that one, but I'd say for the most part, you're committing them to lifelong. The choice after I get them from the heparin to lifelong is either usually a DOAC, so apixaban, rivaroxaban, or warfarin. It's usually one of the two. I would say for these, warfarin is probably going to be a good one for a lot of these. Just be careful with protein C and protein S deficiency. The reason why is when you start a patient on warfarin, they basically they lead to the reduced production of protein C and protein S. And so if you have a deficiency, basically what happens is you drop their protein C and S even more. And so you make them more hypercoagulable. And so they can get like warfarin-induced like skin necrosis, so that they can clot off their skin vessels. And so we always like to make sure they're on heparin for about 5 days. And then once we kind of do that, we'll put them on warfarin as well. And that will bridge them to where you'll cover that little transient hypercoagulable state for a couple days and then get them off the heparin and then keep them on warfarin indefinitely.
And being that it's outpatient, are DOACs just more common, or is it still warfarin's your typical go-to?
Warfarin's a little bit cheaper. I'd say, again, either one of these are a good option. Warfarin probably has a little bit of a higher risk of maybe bleeding. You have to get frequent INR checks, a little bit more susceptible to changes in vitamin K based upon your diet, other associated disorders. So I prefer DOACs. It doesn't need as heavy monitoring. There's less reactions with other kinds. There's like less potential kind of confounding variables in general. And so they're pretty safe. And so I would probably go with apixaban, rivaroxaban over warfarin, preferably.
But sometimes it's not your choice, and the insurance says, "Oh well, we're going to decide for you."
And that's the tough thing. Sometimes insurance is not kind to you.
Always just blows my mind.
I know.
But let's not get into that. Case 2.
All right, let's do it.
All right. We have a 35-year-old female presenting with sudden onset chest pain and shortness of breath. The patient has experienced 3 consecutive first trimester miscarriages over the past 5 years. She was told these were likely due to stress, but wasn't evaluated any further. 2 days ago, she developed left calf swelling and tenderness, which improved with rest. This morning, she experienced sharp pleuritic chest pain and shortness of breath. She denies fever, hemoptysis, or palpitations. She has no prior personal or family history of clotting disorders. For her exam, we get some vitals back. We have a BP 130/85, heart rate is 102, temp is 98.8 Fahrenheit, and her O2 sat is 93% on room air. Just general exam, she is in mild respiratory distress. Lungs, we have decreased breath sounds at the right base. Cardiovascular, she presents with tachycardia, no murmurs or JVD. Extremities, there's mild swelling and tenderness in the left calf. And then skin, we have livedo reticularis noted on the thighs. We get some lab work back. We have the following findings. PT is normal, PTT is prolonged, D-dimer is elevated. We have a Doppler ultrasound that's negative for an active DVT. And we do a CTPA, or a CT pulmonary angiogram, and we find a filling defect in the right lower pulmonary artery. So it looks like we're going to probably have a pulmonary embolism here.
Yeah. Yep. Unfortunately.
What is the most appropriate next step in evaluating this patient's hypercoagulable state?
Yeah. So again, anytime you get like a patient with a DVT, PE, you always got to think about are there other factors, So, obviously I'm looking to see if there's anything in the history that suggests that they have malignancy, they've had surgery, they've had, periods of immobilization, they're smokers, pregnancy, things like that. But nothing really pops out as your traditional risk factors for, a venous thromboembolism. What does pop up is a weird one. And so remember I told you for working up inherited ones, it's looking for a personal, like a very strong family history, first degree relative. Ideally less than 45, 50 years of age of a first degree relative who had these types of VTEs. Recurrent VTEs is another one. And then the other one is clots in unusual locations. What I told you for antiphospholipid syndrome is really, really think about this in patients who have more than three or equal, greater than or equal to 3, spontaneous abortions that are at less than 10 weeks gestation, or at least one, like without any underlying explanation, greater than 10 weeks gestation.
Yeah, that needs some serious investigation.
Yeah.
You can't just attribute that to stress and move on.
Nope. So that's really concerning for me. And so antiphospholipid syndrome is at the top of my differential. Anytime you hear recurrent abortions or recurrent miscarriages in the first 10 weeks, definitely be thinking about antiphospholipid syndrome, especially if they have a clot. Okay. So this patient had a DVT and then a PE. Add one third factor here, and that's the levita reticularis. They love, I'm telling you on the exam, they love to test this on the exam. Levita reticularis, recurrent abortions, and on top of that, DVT or PE, you got to be thinking about antiphospholipid syndrome.
Now, levita reticularis, is that like the modeling?
It's like a weird lacing kind of look. It definitely looks a little bit like a lacing modeling look is the best way to like the extremities.
Let's pop an image up. We'll get that on camera.
I like that. Yeah. So if you see this or you hear it in the vignette, definitely be thinking about that. So when I think about antiphospholipid syndrome, I can send off a panel. Again, it's never a bad thing. It costs money. If you have any consideration to thinking about this patient having an inherited thrombophilia, you could send off all the things that we sent off the last time. So the APC screen assay to look to see if they have any resistance to the protein C for factor V Leiden, checking the G20210A mutation for prothrombin, and checking the antithrombin 3, protein C, and protein S activity levels. And if those are normal, cool, it's not an inherited. But what I always would add to this workup is 3 antibodies. Okay. One is I would check the lupus anticoagulant. 2, I would check an anti-cardiolipin antibody. And 3, I would check an anti-beta 2 glycoprotein antibody. If at least one of those is positive, all right, and I check it twice, and it has to be at least 12 weeks apart. So if I get one of those positive twice, 12 weeks apart, plus they have at least one of the clinical symptoms, recurrent abortions or recurrent VTEs, boom, I got my diagnosis.
Please, God, tell me you're going to treat her PE before doing that.
No, I'm going to let her simmer a little bit.
That's a stupid question. Just had to make sure about that one.
No, I definitely would be, but at least to get my diagnosis, I would do this workup.
Sure. All right, awesome. So then my next question is, what long-term treatment considerations are important if antiphospholipid syndrome is confirmed?
Yeah, so treating this, I would start acutely. I would put them on heparin. There's no evidence here to suggest that they need like TPA or like an embolectomy or anything like that. They're not hemodynamically stable. And I don't see any mention of an echocardiogram showing any RV strain or even the CTPA showing any RV strain. So
meaning that they are hemodynamically stable.
Yeah,
we're okay.
So I don't think I need to do any TPA or an embolectomy or anything like that. So then it comes down to just anticoagulation. So this is kind of one of those who are a little bit more lower risk. Like these are, I'd say, a stable PE. And so for this one, it's just anticoagulation. I would start off with heparin. Low molecular weight or unfractionated heparin would be the go-to choice. Same thing like in case 1. Mm-hmm. And I would just do that until I get them therapeutic. Then once I've done that, I would start them on warfarin, and I'd probably keep them on warfarin forever.
Yeah.
Just the reason why is they're high risk. They're at high risk of a patient developing another DVT or another PE or weird types of clots in unusual locations, recurrent abortions. And so for this scenario, warfarin is the drug of choice for antiphospholipid syndrome.
And then would their INR goal still be like your conventional, like between 2 to 3?
Yeah, this one doesn't have a mechanical valve, so I wouldn't push it higher. So I do the classic 2 to 3 INR and kind of closely monitor that. Sometimes they add in aspirin. I don't know if I'm always an advocate of adding that on. I would say that I would stick with heparin. The reason why they add on aspirin is kind of interesting. I mean, it's cool, but I don't think it's absolutely necessary, but it's not going to hurt them. Aspirin is good because patients who develop antiphospholipid syndrome, they're not just at risk for venous clots, they're at risk for arterial clots. So especially if it gets catastrophic. So if it gets really bad, sometimes it can take down like a coronary artery. And so aspirin is usually a go-to in that scenario. If you develop a clot sometime within the cerebral vasculature, you can develop a stroke. So aspirin's good for that. And then if you develop kind of a clot within the lower extremity, you can get a limb ischemia. And so aspirin may be good for that. So you can definitely consider those things. I wouldn't be my first go-to, but I would say heparin, and then eventually transition or bridge them to warfarin indefinitely.
Now, the patient did present with a prolonged PTT.
I know you noticed that, right? That was weird.
Yeah. So with this patient, would you do a mixing study?
Yeah, so having a prolonged PTT would mean that you're more likely to bleed, right?
Yeah.
And this patient's clotting. And so it's definitely odd. And so that's one of the things that you see because of one of the antibodies. So lupus anticoagulant causes, funny enough, in us, in our bodies, it causes clotting. But when you put it in a test tube and you test it with like plasma, it doesn't cause clotting. It actually prevents clotting. And so it's a weird thing where in that kind of study, it precipitates an anticoagulant effect, which prevents bleeding, and that prolongs the PTT. But in our bodies, it does not do that. And so it actually does lead to activation of, procoagulants, or actually a decrease in anticoagulant proteins, and that then precipitates clotting. And so it's weird. So for this one, you wouldn't really have to do a mixing study, but if you did, think about this, you have a antibody. So if you give them some type of plasma, that antibody is just going to keep binding and keep binding to whatever you're giving them, and you're not going to result in a normalization. The only way that you can really normalize this is you have to do you have to add in phospholipids. So if you add in phospholipids, then the antibodies will bind to the phospholipids, and it'll allow for the platelets and it'll allow for the anticoagulants to work. And so the only way that you can truly normalize the PTT and antiphospholipid syndrome is you have to give them normal plasma plus add phospholipids and calcium and other couple of different things into the solution to normalize it. But it won't normalize with a regular mixing study, and it won't normalize with what's called the dilute Russell Viper venom test, which is a big one for the exams. Watch out for that one.
all these names and abbreviations.
I know. Hematology is a son of a gun.
It's been tough.
Yeah.
Last question here. Are there any pitfalls you should be aware of with antibody testing for APLS?
Yeah, so I watch out, if you test them and they come back positive for syphilis. Weirdly, one of the antibodies, the anticardiolipin antibodies, can actually cause a false positive like RPR or VRDL kind of testing. So that's one thing to consider.
That's a tough one.
Yeah, and you'd have to do like a more of a confirmatory test with the fluorescent kind of antibody test.
All right. Well, that leaves us here to our final discussion, more of just a general discussion on any suspicion of other causes of acquired thrombophilia.
Yeah, I think that's good because we talked about all the inherited types and we talked about the main acquired one, but yeah, you can get other acquired thrombophilias.
With that being said, when should you suspect other acquired causes of hypercoagulable states, and what tests should you order, or what tests are really ideal?
So again, I would always stick with the same thing, like some degree of like in these patients, if it's not an inherited one, then you're not looking for a strong family history, but you can see recurrent like VTEs. Clots in unusual locations is a really, really big one. So that's a really, really big one. So I would say for me, so the first one is you think about what's called paroxysmal nocturnal hemoglobinuria. So if you see a patient with dark urine in the morning and they have a clot in like a portal vein or a cerebral vein, and then they have hemolysis, episodes of hemolysis. So they have a decreased hemoglobin. They have evidence of hemolysis, which is an increase in LDH, a decrease in the haptoglobin. and schistocytes potentially being found on peripheral blood smear, then I would suspect paroxysmal nocturnal hemoglobinuria. So again, dark urine in the morning, evidence of hemolysis, and then clots in very weird locations like the cerebral or the hepatic veins. Those are the ones I would think about. Another one to think about is myeloproliferative neoplasia. So this is in patients who have what's called polycythemia vera or essential thrombocythemia. They have what's called a JAK2 mutation. And basically what this does is this creates this hypercoagulable state, but I'm going to kind of say it in a weird way. The hypercoagulable state is polycythemia vera is you increase your number of red blood cells, which increases the viscosity of the blood. And if you have a more viscous blood, compare water to like syrup. So it's going to be easier for that syrup to kind of like very, very slow and kind of get sludged up, and it can create kind of a hypercoagulable state, if you will. So polycythemia vera can cause that. So look for really high red cells, and you'd have to see a JAK2 mutation. And clots in weird locations. So clots in weird locations is really big for that one. So hepatic, portal vein, again, some type of hepatic vein, portal vein, mesenteric vein thrombosis, high red cell count, and a JAK2 mutation, polycythemia vera. Essential thrombocythemia is a very high platelet count. So if you have lots of platelets, they can clump, they can lead to clots easily. And so that can also lead to clots in unusual locations. So clots in unusual locations and a really high platelet count with a JAK2 mutation, think about MPNs. The other one I think about is rare, but definitely have it on the differential, is heparin-induced thrombocytopenia, HIT. So if a patient has an exposure to heparin within the past 5 to 15 days, they have a sudden drop in their platelet count, and on top of that, they have clots, DVTs, PEs, or even arterial clot in like the carotids, some part in the brain, or causing a heart attack, an MI, or limb ischemia, you definitely have to think about HIT.
Which is another weird one because that would be really considered a coagulopathy.
Yeah, it's a weird one because in this scenario, you would think, okay, this is, again, you're causing a decrease in the number of platelets. You would think, oh, I would think they would bleed, right?
Yeah.
Yeah, and so you would think that. The only problem is that the platelets are getting consumed to make clots, and that's why it's an odd one. Yeah. Gotcha. Malignancy is another one, but this is, again, I would say out of all the acquired causes of hypercoagulable state, malignancy is going to be the most common cause.
Right.
So any kind of cancer, any kind of solid organ tumor, they love to test pancreatic cancer on the exam just because they like to say a patient who comes in with like abdominal pain, some nausea, and then they have, this is the key sign, migratory superficial thrombophlebitis. So they have like very, very inflamed red, hard vessels. So migratory superficial thrombophlebitis, kind of abdominal pain, maybe a history of alcohol abuse. Those kinds of patients are super, super common to have pancreatic carcinoma, and that can cause a Trousseau kind of like syndrome, which they present with this hypercoagulable state.
And let me guess, also some clots in unusual locations.
Yep. Yeah, they could definitely cause clots in unusual locations.
It's been a recurring theme.
Yeah, so clots in unusual locations, definitely think about paroxysmal nocturnal, myeloproliferative neoplasia, and I would even think about, as you said here, malignancy. But malignancy by far is going to be the most common cause. HIT, really just think about that when the patient is taking heparin and all of a sudden they see a drop in their platelets plus clots, which is completely paradoxical, as you said, from what you would think.
And then just one more quick recap of the diagnostic testing that you would use for these.
Yeah, so if I have a suspicion of an acquired type of thrombophilia, I would send off those tests that I said before for antiphospholipids. So I'd send off the lupus anticoagulant, the anticardiolipin, the anti-beta-2 glycoprotein. And then if I see hemolysis, dark urine, clots in weird locations, I would check a flow cytometry for CD55 and CD59.
And this is for PNH?
Yeah, exactly. Okay. For myeloproliferative neoplasia, if I see really high red cell count or really high platelet count, and I see that they have clots in unusual locations, I will check a JAK2 kind of like mutation. And that usually can give me an idea, especially if the platelets are high, it's essential thrombocythemia. If the red cells are high, it's polycythemia vera. HIT, heparin exposure. So you do what's called the 4T score, if you guys remember back from the platelet disorders. But you have to check to see if heparin exposure, 5 to 15 days, really significant drop in the platelets, thrombosis, and no alternative explanation. From there, you can just, if you have a very high 4T score, you go straight to the serotonin release assay and it'll be elevated. If it's kind of like a little bit tougher, you can check what's called the PF4 antibodies. And if those come back positive, then you check the serotonin release assay. Malignancy, it's really, they love to test this on exam. So when a patient comes in and they have a DVT or a PE and it's due to a malignancy, or you work them up for everything. You work them up for an inherited thrombophilia, nothing. You work them up for an acquired one, like antiphospholipid, PNH, MPN, a HIT. None of those come back. You need to think about malignancy.
Yeah.
And so this is the solid organ ones. And so you have to do this is the key word, age appropriate cancer screening. So, and then symptom specific as well. So if a patient came in with hemoptysis or shortness of breath and coughing and fever and night sweats, what would you'd probably get like a chest X-ray.
Lungs.
Yeah. Because look to see if they have lung cancer. If they said, I got abdominal pain, I got these weird like red inflamed veins in my arm, or just red lines, hard lines on my arms, and near my liver, it feels like it's rock solid. I'd probably get like a CT of their abdomen and pelvis, make sure they don't have pancreatic cancer. So it's age appropriate cancer screening, and again, symptom specific as well, that could guide, there's a malignancy that's created a hypercoagulable state that caused their clotting. That was a lot.
That was a lot, but it was good. It was good information. It was jam-packed.
Yeah. This one's a tough one when you think about it, because there's a lot of testing that you would have to do right off the get-go. Like if you have a suspicion of inherited thrombophilia, you have to send off a lot of different assays to see which one could it be. And then if it's not, or low suspicion of inherited, then you have to think about those acquired cases. With the most common one, it's going to be malignancy. But don't forget about the things like antiphospholipid, paroxysmal nocturnal hemoglobinuria, HIT, myeloproliferative neoplasia, because the step 2 CK will not forget those things.
Yeah, they love the weird rare stuff.
Yep, anything rare, they're going to add it.
Awesome. Well, that would be then our podcast episode on hypercoagulable states. Really good one. That was, that was a lot of information.
Yeah, and I hope it made sense, and I really hope that you guys enjoyed it and learned a lot, and I hope you had fun listening to this. And so we love you. We thank you. We'll see you the next time. And again, as always, until next time.